أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. My dear friends and students and colleagues, I was actually previously telling you about the fungal infection that is called mycology. For the human interest, I have divided actually into three types of the fungal infections, which are not uncommon to the humans. And first are the superficial infections, means that it is purely epidermis of the skin are involved. Second one is subcutaneous fungal infection, dermis or lower down fascia, facial sheaths are involved. They are called subcutaneous fungal infections. And third type of fungal infection are deep type of mycosis or fungal infection, which penetrate inside the different parts of the body or organs. I am Professor Ali Haidar. I am honorary global professor of medicine without any name, fame or economics. This channel is free for all and it is not monetized even, and not seeking for the money or dollars, etc. All expenses which I have done on the production of these videos, I have done myself, and some of my colleagues have also participated in the instruments are concerned which I am using now. Otherwise, all expenses were purely from my side. I am also using the other type of gadgets. You see in a few months that how to examine the patient, the presentations, etc. And how we will pick the physical signs and diagnose on clinical basis. That will be in a few months you will see. Today I want to discuss section 1, and this is subcutaneous infection, SPOROTRICHIASIS, CHROMOBLASTOMYCOSIS, and eomycotomas. Today only SPOROTRICHIASIS and CHROMOBLASTOMYCOSIS will be discussed. To cut short and to memorize it. In session 1 and session 2, I will take the eomycotoma or mother of foot. Now look these beautiful flowers. जहाँ पे फूल होंगे वहाँ कांटे भी होंगे. वो कहते हैं कि फूल तो मुरझा जाते हैं, कांटे जो होते हैं वो हमेशा रहते हैं. इस किस्म की शायरी in poetry has been given, already mentioned out in different parts of the Urdu-speaking people who listen about the roses, about the thorns, and about the leaves, etc. Istiara, etc. They are using istaras for this. For Mahbub and the person who is Ashik and the other one who is opponent. BCQ, a 35 years gardener, expert in cultivation of roses, noticed the maculopapular crusty lesions on both hands and forearms. Since 1 month, he was on oral steroids. Since 2 years, prescribed by the VA for the asthmatic attacks. The most effective therapy in this case would be, first of all, this condition is related with roses. Probably it is source of infection. It is SPOROTRICHIASIS, but the other fungal infection and other infection may be possibility. So it is on both hands and forearms, upper limbs are involved. This is the infection which is related with the skin and under the skin. So this has the broad spectrum that beta-lactams are effective, or itraconazole or antimonial compounds, or PUA therapy, and amphotericin B. This is the differential diagnosis of this case actually. That it may be a cellulitis, it may be a fungal infection, or a subcutaneous or deep antimonial compound. It may be possibility of the leishmaniasis, or it may be possibility of the psoriasis. It may be possibility that the disease is actually inside the body and reflecting on the skin. Like, for example, fungal infections, coccidioidomycosis, etc. So amphotericin B, which be used in the deep mycosis. But this is a difficult case to deal. Definitely, when occurs, you have to focus that patient was on steroids, stomach attacks, weights have been given the steroids. They don't know how to give the steroids. So there is immunosuppression in this case. Probably this is the problem that the fungal infection occur, and it is most probably related to the roses. That is why I said it is sporotrichiosis. Trichiosis means, that is a hair. Sporo means spore formation. It's also known as the rose handler's disease. Is a fungal infection that may be localized to the skin. Probably this is the most important inoculating site. But it may spread to the lungs and the bones and the joint. It becomes systemic then. Although it is not very common, it presents with a firm, painless nodules. Remember what are nodules? Nodule is above the skin, and it should be more than 1.5 centimeter at least. That later ulcerate. Following initial exposure to the Sporotrix chancaitis species, the disease typically progresses over a period of a week to the several months. It will take much time for the progression. Serious complications may develop in the people who have a weakened immune system, like the previous case I have told you that the Ved or Hakim has given the oral steroids to suppress this condition. Probably, other than the suppressing the condition, the disease spreads very, very quickly because of the immunosuppression. This is a cytological preparation of the case of the feline cat sporotrichiosis. Phagocytic cells show numerous variable shaped yeast forms. This is yeast form inside. You see this one. The high power microscope, low power microscope. Etiology and method of spread that the sporotrichiosis is caused by the fungi of the sporotrichiosis chancai species complex. It is complex. It may be other species of the sporotrichiosis may be involved. Because the sporotrichiosis chancai is naturally found in the soil, it is found in the hay, sponginium moss, and the plants. All cultivating conditions, in most cases, it most often affects the farmers, gardeners, and agricultural workers. What are the diseases which are affecting the farmers? What are the diseases affecting the gardeners? And what are the diseases acquired by the agricultural workers? It was asked actually in 2014 examination by a foreigner examiner. When he saw a condition which is under the differential diagnosis of fungal infection, he said that, tell me about the diseases of this specific diseases. One should know about it. One should know. It enters through the small cuts in the skin because of fungal infection. In cases of the sporotrichiosis affecting the lungs, it is a invasive sporotrichiosis. The fungal spores enter by inhalation. This is a very rare condition. It is not common. Sporotrichiosis can be acquired by handling cats, feline, because cats are the most favorite host for the disease other than cultivating lands with the disease. It is an occupational hazard for the veterinarians. It is occupational hazard because they are handling the animals like the lambs and others. They are grazing on the lands where the fungi goes on the skin, on their skin and the mouth, and that is why the veterinarians they can acquire the disease. This is the clinical presentation, cutaneous type. The people get sporotrichiosis by coming in contact with the fungal spores and the environment. Cutaneous skin lesions. Look, this type, one nodular, two nodules are there. Intermittent areas are The clustering is seen here. Cutaneous infection is the most common form of the infection. It occurs when the fungus enters the skin through a small cut or scrape, usually after someone touches contaminated plant matter. The first symptom is small, pink, red, purple, painless bump, resembling an insect bite. The bump or lesion usually appears on the fingers, hand, or arm, where the fungus first enters through a break in the skin. The clinical presentation, other than that, cutaneous or subcutaneous, there is pulmonary sporotrichosis, which is a rare form, very severely immunocompromised patient, like for example HIV, can acquire in this type of infection. The pulmonary sporotrichosis is a rare condition. It can present as a primary pulmonary disease resulting from the direct SPOROTRICHIASis or Candida inhalation, or as a part of the multifocal sporotrichosis with multiple organ involvement, mainly in immunocompromised patients. Now you see a lot of, it is globally involved in this condition. Only some zones, upper zones, are left. Otherwise, all you see there are macronodular type of infiltrations are seen. All the costophrenic angles is here is slightly hazy, but it is not pleural effusion. Clinical presentation in dissemination is concerned, the whole body is involved. Disseminate by beyond the lungs to the other parts of the body. Most often, these parts include the skin, the bones, liver, brain, heart, and the membranes that protect the brain and spinal cord meninges. It occurs actually in AIDS patients. In the HIV affected patients, possibility of this type of dissemination can occur. How will you diagnose? Sporotrichosis is an acute infection with slow progression because it is progresses very slowly, and often subtle symptoms are seen. It is often difficult to diagnose as many of the diseases share similar symptoms and therefore must be ruled out. A lot of differential diagnosis can be made. Patients with sporotrichosis will have antibodies against the fungus Sporotrichos shanghai. However, due to the variability in sensitivity and specificity, antibody detection may not be a reliable diagnostic test, because a lot of species are intermingled with it, and they also cause the same type of what is called a morphological texture of the antibody. That is why it is false positive, it may be false negative. The confirming diagnosis remains the culture in the fungus from the skin, sputum, cerebral fluid, and CSF smears should be taken from any draining fistulas or ulcers. The media should be very specific, that is called suborder media, and then you subculture it with the other media. Treatment is definitely second or third generation azoles are effective. Oral itraconazole 200 milligram orally once a day, given until 2 to 4 weeks. It is 4 weeks. After all lesions have resolved, typically 3 to 6 months is the treatment of choice. Let's go for the LFT. LFT is normal because it will definitely harm the liver, and the cholestasis occurs when you give the itraconazole. So try to go for the follow-up with the LFT. They are normal or slightly deranged, go on, no problem. Otherwise, it will harm the condition and cause the cirrhosis of the liver in the end. Severe infection requires a lipid formulation of amphotericin B. In severe, definitely you are used to a very high potency antifungal like amphotericin B. After a very favorable response, treatment is switched to oral itraconazole afterwards. For the total of 12 months of treatment, if it is severe infection, brains are involved, brain and kidneys are involved. AIDS patient may require lifelong maintenance therapy with itraconazole for meningeal and disseminated infection. A new drug is the third or fourth generation is called posaconazole, may have a role, although it is not available freely in this country. The second condition was very rare. It is nauseating, terminology, the CHROMOBLASTOMYCOSIS. Look, this condition is, I have, at one time I learned about it many years before. But this condition, why we are learning this? Because to acquire knowledge. If somebody has got this condition, it is possible that we missed it. Of course, we can miss it. You refer to the dermatologists in this country. The cosmetic dermatology is in practice mostly. The cosmetic dermatologists will have not have enough knowledge of the internal medicine. Those people who have got the internal knowledge of internal medicine and they done afterward the dermatology, then they are able to pick this condition. Otherwise, it's difficult. The chromoblastomycosis is a long-term fungal infection of the skin and subcutaneous tissue. It is called a chronic subcutaneous mycosis. That is very, very common in some countries. It can be caused by the many different types of fungi which can become implanted into the skin, often by thorns again or splinters. It is not related with the rose, but any thorn can do it. Or splinters. It's possible that splinting has been done, and that is causing the abrasion of the skin, and the infection will travel. The chromoblastomycosis spreads very slowly. It is rarely fatal and usually has a good prognosis. So that it progresses very, very slowly, but it can be very difficult to cure. If it is entered into the subcutaneous tissue, definitely it is not very easy to do it like the previous one, that is SPOROTRICHIASIS. The several treatment options include medication. You give the medication like itraconazole or prosconazole, and then you do the surgery of the limb or the area should be abraded surgically. The infection occurs most commonly in the tropical or subtropical climates, often in the rural areas. You are living in the tropical zone, so this disease may be possible in our zone, Far East Asia. Micrograph has been showing the sclerotic type of the bodies. Now this is the high power microscope. Inside you see that is the sclerosis are seen around this, the spores of the chromoblastomycosis. This is the sclerosis. It's causing the sclerotic bodies, which is seen in this condition, which is not seen in the SPOROTRICHIASIS or other, I will say, in the eumycetomas. They are not commonly seen, this type of a picture, electromicrograph picture. Now, a 34-year-old man with a 12-year history of the chromoblastomycosis and electron microscope showing the Fungal pedrosis spores. This is one of the species which is causing this. It is under the heading of the chromoblastomycosis. It is one of the species. So this lesion is shown here, how it occurs in the different parts of the knee joint. Here it is involving like this. It is possibility of any lesion, like psoriasis, like eczema, like other than that, it is possibility of a bacterial infection. Under the microscope, you find that this is how the flowering effect. It is just like a pedrosia spores. Pedrosia. These are spores which are coming out from this spongium. For spongium, they are burst and releasing the spores to affect the other parts of the body. Clinical feature: the initial trauma causing the infection is often forgotten or not noticed. The infection builds at the site over a period of years, and a small red pupule skin elevation appears. The lesion is usually not painful. With few, if any, symptoms, patients rarely seek medical care. It is fine. They don't know, but okay, this is done, no problem, because there is no clinical features associated. Several complications may occur. Usually the infection slowly spread to the surrounding tissue while still remaining localized to the area around the original wound. And however, sometimes the fungi may spread through the blood vessels, spongemia, or lymph vessels, producing the metastatic lesion at distant sites. It is possible. Another possibility is secondary infection with bacteria. The bacteria will secondarily infect the lesion. This may lead to the lymph stasis obstruction of the lymph vessels and causing the massive edema that is called elephantiasis. The nodules may become ulcerated, or multiple nodules may grow and coalesce, affecting a large area of the limb. Small nodules, they become aggregated on one side and ulcerated and coalesce, and the ulceration is a big ulcer will form in this fashion. Diagnosis, again, you have to do the scrape of that lesion and then add the potassium hydroxide. This is main important what you can say before staining. We use this liquid, then examine under a microscope, and in the light microscope, then potassium hydroxide scrapings are commonly used to examine the fungal infection. If you are suspecting a fungal infection, the first step is the potassium hydroxide. You go for it and see it is very clearly visible. The physiognomic finding is observing what is called medullary bodies, also called myriform bodies or sclerotic cells. This is a unique thing which is seen with the CHROMOBLASTOMYCOSIS. What is called sclerotic cells or myriform bodies. They are well known as medullary bodies. Scrapings from the lesion can also be cultured to identify the organism involved. Blood tests and imaging studies are not commonly used. On histology, CHROMOBLASTOMYCOSIS manifests as pigmented yeast resembling the copper pennies I have shown you previously. Special stains such as periodic acid shift and gomari methamine silver can be used to demonstrate the fungal organism if needed. If you are not sure, do the special staining and then see under the high power microscope. Treatment is the same one as I would say the azoles. And one is giving flucytosine was practiced at one time, but itraconazole or other third generation. It may combine some people combine itraconazole with flucytosine, but it is not necessary. This agent is very powerful. Alternatively, cryosurgery and liquid nitrogen has been shown to be effective. Cryosurgery, liquid nitrogen, to burn it out. Other treatment options are the antifungal drug, which is called terbinafine. This is very, Lemazil. It is available in Pakistan as a Lemazil tablet, 250 milligram. Another fungal azole is called posaconazole, not available easily in Pakistan. And you go for the heat therapy. A specific temperature, you do the sponging with the heat. Antibiotics may be used to treat bacterial superinfection are very common in this condition. Antibiotics should be added. If it is very invasive, then you use or resistant, then you have to use the amphotericin B has also been used. And photodynamic therapy is a newer type of therapy, photodynamic, used to treat the CHROMOBLASTOMYCOSIS. It is not commonly available. Photodynamic means that by the rays of light rays, you use in a dynamic fashion the rays which are photons, actually called photons. They attract the CHROMOBLASTOMYCOSIS lesions, and they say that they are effective, but they are under the research now. This is the session 1 of the subcutaneous mycosis. I hope that you think that they are not important, but I will say that they are important because you are a clinician. You should know at least the name of the condition. And it should be known that they can be spread in the agricultural land, farmers, and those people who are veterinarians, etc. This is the message which is given to you. Otherwise, if you want to gain knowledge, repeat this video again and again 2 or 3 times, you can understand. I hope this is beneficial. وَمَا عَلَيْنَا إِلَّا الْبَلَاغُ.